This is a filling done on a person in their mid-20s. You can see the x-ray, tooth number 19 with the little green area. It was very difficult to see actually on the x-ray. There was also a filling tooth number 15 that if you went back and looked at might need to be replaced. The area on the x-ray was a little bit darker. Here's the filling, and you can see in the mirror the dark spot. We're removing the area of decay, just being very careful. And as you can see, the brown spot is larger, which is very characteristic of decay. Once it gets past enamel, it starts getting into the softer next tooth structure called dentin and becomes larger and larger. And so we're removing the weak area that's connected to that, and we'll go ahead and remove all the infected area and clean out the decay. This is a water driven handpiece, and it's actually an electric one so that we can go at different rates. And we like to use water when we're removing enamel because we don't want to heat up the tooth. And you see all those other little brown areas, and some of those actually have a little bit of depth to them. And in the previous years, people would just connect them, kind of like connecting the dots, but that does remove a little bit more tooth structure. In this video, you'll actually see me use a pointed cone to go in and just remove those, and then use some filling material to fill that in. You can see that the decay peels away with that spoon that I was just using. Here's another illustration of that. And this is at about 10 to 12 magnification. This is the lower left first molar. And as we can see, there's still more decay that needs to be removed. And so we're going in and slowly removing that. We've decreased the amount of RPMs. It's actually 2,000 with the electric handpiece. And I'm using a mirror, and so this is done indirectly. You can see the gray side of the mirror just in the outside of the video there. I can actually see more than what's shown on the video, and so I have a significantly better view. And I want to make sure that there's no decay left behind, and we'll come back and check with a spoon excavator in just a minute. And sure enough, I'm still peeling away some of the tooth. And you'd like the tooth to be hard, not soft. That's particularly true if you have more than enough room before you would enter into the nerve area. It would be a little bit different if I saw pink material. I would do a pulp cap. But this is really a fairly shallow lesion. We're just trying to make sure it's all completely cleaned out. And I'm going to go ahead and use a micro etcher to see if I can get some of the brown stain out. And this is aluminum oxide that's basically removing a little bit of the stain and a tad bit of tooth structure. And as you can see, it's not very effective, though we do use it also inside the cavity area to make sure that that's nice and clean. You can also see in the little corner there where this particular patient has been grinding his teeth. You can see where some of the enamel is missing. And we're going to fill those up. Here's the little pointed cone. And under that magnification, I can get a pretty good idea. You're not getting, here we go, here's the mirror indirect vision, and that's a little bit better in terms of being able to tell if there's still any sort of decay or possible weak area. And for the areas that were just little brown stains, then we would be doing what would be called a preventive resin restoration. I could always leave this behind, but if they turned into cavities and we had to do them in the next year or two, the patient's insurance would look at that and say, well, you already did the filling before, and they would not honor it. It's a better procedure for the patient that's on insurance to have all these little areas taken out and to do it as conservatively as possible. Usually that works out very well. Occasionally one might pop out, but it's easy enough to rebond it. On the other hand, if you wait until they become cavities and the patient's insurance company notices that you did one filling already on the tooth, they will tell the patient that they won't cover it, and then that second filling, which is done maybe a year or so later, would be charged to the patient. Here we're pretty close to getting everything cleaned up, and you might ask, well, there's a little brown spot on the buccal area, and that's a different surface, and the laser that we use didn't detect that as being a cavity. And what about doing a preventative one? Well, it's not on the same surface, and it's just a lot easier to monitor it with the laser and go back and take care of it. We've been using chlorhexidine for kind of a disinfectant, removed bacteria, and then we come back and use SE bond for the actual filling. This is the primer, and we follow that up with the bonded material and cure that. Once that's been cured, this is a little bit of flowable that is placed into each one of the little spots, and I use an Explorer to make sure that the different areas are covered. And then the filling material is sonic flow fill, and I like that because, here's the Explorer, I like the sonic fill because it's actually pushes the flowable out of the way, and most of the filling, it turns out to be the sonic fill. I find that that gets the best adaptation and allows us to have the most enduring filling. Here's the sonic flow placed in the filling. You can see how it's pushed up. A little bit of a black area from the black plastic, and it wouldn't be the end of the world if that was incorporated. I actually go back and make sure that that's not there if I'm able to detect it. I just like to have the filling completely done. A lot of people will tell me that I should be using a rubber dam. I've been doing this for many years, and I've been able to maintain a dry field, and the fillings have worked out well for me. One of the benefits of staying in the same practice for 30 years is you do see your fillings. Here's the initial fillings in place. I'm using a multi-fluted finishing burr to polish off some of the composite. I come back with a polisher, and this is an aluminum oxide polisher that polishes away the filling but not the tooth. We use a second one that's a higher, better polisher, finer polisher, and then there's the filling, and you can see how nice and smooth that is. You can also see where the patient has been grinding his teeth a little bit in the back there, and it's got that U shape, which is not characteristic. You could look at the video on his mouth exam